Okay, we can get started. So welcome everyone. This is actually the first of the third season, first event of the third season for these MOHCCN seminars. I think they're very popular. I think this one should go smoothly. And we're happy to have people from PMH. So this is the Ontario node of MOHCCN. And we have our patient partners, James Pereira in particular, who is there and is going to act as co-chair, I think with you, Veronique, right? So without further ado, I would like to pass this on to you, Veronique.
Merci, André. First of all, I just want to acknowledge that we are using a new platform, so I want to thank everyone here for their patience in advance. We will be keeping questions till the end. We'll put something in the chat, but please feel free to use the Q&A function. It should be at the top right of your screen if you want to ask any questions, or you can raise your hand at the end and we'll unmute you. I do want to take just a quick moment to acknowledge that I personally am calling in today from Mi'kma'ki, the traditional and unceded territory of the Mi'kmaq people. Our network members and our speakers and our attendees today are located all across the country on lands that are home to diverse First Nations, Métis, and Inuit population. So I invite everyone here to recognize those Indigenous peoples and reflect on the importance of those lands. I do, as André quickly mentioned, I also want to introduce my co-chair, James. James is one of the inaugural members of the network's patient working group. He's done so much for the network since joining almost 2 years ago now. And on top of everything that he and the rest of the group are already doing, James generously volunteered to participate and co-chair today's event. So thank you so much for joining us, James. And I'll pass it to you if you'd like to tell us a little bit about yourself.
Thank you, Veronique. Firstly, I'd like to acknowledge as well that I'm on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. Hello, everyone. As Veronique mentioned, I'm a member of the MOHCCN's patient working group. I'm also a volunteer driver with the Canadian Cancer Society's Wheels of Hope program, taking people with cancer to their cancer-related medical appointments. As well, I'm a patient survivor caregiver reviewer with the Canadian Cancer Society. And although I have an undergrad degree in zoology and biochemistry and a master's degree in biochemistry and molecular biology and some toxicology research background, since coming to Canada almost 30 years ago, I found my way into the performing arts industry. But like many people here, cancer touched me from an early age, having lost my father to lung cancer when I was 24 years old and had several others close to me pass away from cancer as well since then. So it gives me a great sense of gratitude that my life has found its way to the cancer research field in the last few years, especially in this advocacy role, and especially to the patient working group, the members of which lift me up every day and truly epitomize what I call the miracle of hope. And that's what brings us here today, to learn about some of the great research and advances in cancer research, specifically with the Ontario Consortium of the MOHCCN. So knowing very well that you didn't really join us today to listen to me, I'm honored to introduce our speakers today. Our first speaker is Dr. Lillian Siu. Dr. Siu is a medical oncologist at the Princess Margaret Cancer Centre at University Health Network. Dr. Siu is one of the consortium's leads for Ontario, and today will be giving us an overview of recent activities within the consortium. Go ahead, Dr. Lee.
Oh, okay. Do you want me to start? Okay, great.
Yes,
I'll share
please.
my screen. Can you all see it?
Yep.
Okay, great. So first of all, thank you, James. it's very humbling for us to be introduced by you. You're such an accomplished individual, and thank you for all you do for MOHCCN, and thank you for all you do for science. So I'm honored to be the introduction. Hold on, I'm trying to make sure I can advance. I'm honored to be giving an update of our consortium. As you heard, I am the co-lead for the Princess Margaret Cancer Consortium, together with Enrique Sanz, who you will hear later on the Molecular Tumor Board. Just go right into it. The PM2C is, as you all know, one of the founding consortia of MOHCCN. We have grown over the years in terms of people as well as projects. Currently, we have, as you can see, at least 113 people and growing number of individuals working on the various projects, in addition to external team collaborators, for example, and we have close to another 70 people outside of the core group that works with us. So in total, as you can see here on the screen, there's probably close to 200-300 people working on MOHCCN at the Princess Margaret Cancer Consortium. I'm just not seeing the arrow. There we go. So I just want to give everybody a quick update. We have some change in personnel. I think many of you remember Emily van der Laar, who is still part of this team, but she'll move on to more of an architect role to really help to harmonize and integrate data across the University Health Network, including MOHCCN data. And Ailey and Prab, who have been working closely with Emily, will be moved on to a more senior co-lead role in terms of managing projects within PM2C. We have Robina, who works with us, as well as Matt with us. And I think everybody knows Savan, who handles all the financial matters of MOHCCN for us. So just to show everybody some of the new roles that the team is taking on. This is from the dashboard from MOHCCN. As you can see, I think as of February 2025, we're close to 8,000 cases in total and growing very quickly. I think we can say that at Princess Margaret Cancer Consortium, we have been a fairly active contributor. We've contributed close to 25% of the total number of cases, and many of the clinically annotated cases are coming from our consortium. And all the team project coordinators as well as PIs have been working very hard, and I will obviously thank them at the end, but I also want to do a shout out right now for all the work they have done to populate and annotate these cohorts. Just to show a timeline of our growth, we started our first case for MOHCCN in summer of 2022. And as you heard, we are close to 2,000 cases sequenced now. This year, we have exceeded our 500 patient caseload. We expect that we will continue to exceed our committed caseload next year as well. We also have been named the Secretariat of the Ontario Cancer Consortium. I'll highlight a little bit at the end. I think we have done very well in terms of bringing many sites in Ontario together and allowing them to be a part of this important Canadian precision medicine effort. You'll hear a lot about the tumor board, so I will not take away Enrique's thunder for that. You can see that the cohorts that we have are across different disease sites. And importantly, I want to point out that our hematological colleagues, our blood cancer colleagues, lymphoma, myeloma, leukemia are also part of this. Very often precision medicine gets focused on solid tumors. We certainly do not want this to be the case. So we wanted to make sure it's across all diseases, solids and liquids. I think the other unique aspect of our consortium is that we have also opened our gates to our surgical colleagues. So some of the cases are early cancers after surgery, and we use their surgical samples for profiling. So I think that also is a very unique characteristic as well. You can see in this particular slide a summary of all our cases or our cohorts. There are obviously the standard cohorts that we contribute to the MOHCCN, but we also have a lot of projects in addition. We have the Pan-Canadian project, we have our informatics and data science award projects. We also ask people who attend our every 2 weeks call that if they can see themes across cohorts and think of projects, they can also propose that. So there are 5 ongoing. They're the Tech Development Award projects. And then within the single cohorts, within the PM2C, there are also actively ongoing projects. So there are in total, close to 40 projects that are ongoing at this time. We've been very active, especially shout out to Emily van der Laar, who's been very active in the data group that have been helping to move our data into the S3-E1 data model. So all our data currently that is curated is sitting in the data model 3.1. And I think our template for our REDCap has been shared with the network so that people who don't want to build their own REDCap can use the REDCap database CRFs that we have created and contributed to the network. Just a few things to highlight. We have been doing immunohistochemistry as well, using panels through the immunoprofiling lab here, led by Pam Ohashi and Ben Wong. And we also, within that, have been awarded the Tech Development Award project to work with Kingston, with Amber Simpson, with Sinai Health, Kieran Campbell, and the NCI US with Eitan Rupin, really to see how we can characterize lymphoid structures, tertiary lymphoid structures, which are known to be predictors of immune response. You can see the cocktail here that we're using to stain tumor slides to look for TLS. And the idea really is in time we'll be able to use our data to develop AI algorithms to look at H&E slides and select out tumors that have TLS without necessarily to do all these stains. And a lot of that work is in collaboration with the partners that I have mentioned. This is just one example of a melanoma study patient in the MOHCCN cohort that has a TLS. You can see it's almost like a lymph node, but it's not a lymph node, where it has a lot of immune cells and a germinal center under the microscope. And the stains are really to characterize these particular structures. Just want to show all the various awardees over the years. I won't call out all of them because that would take up a lot of time, but a lot of them are young investigators, as you can see, who've been working with a lot of the more senior investigators. Many of them have presented at our every 2-week meeting here to showcase their work, to keep everybody sort of in the know, and also to generate new interest for new projects as well and collaborations. And it goes on as well as to the recent Tech Development Award. And we also have our recent Patient Awards winner with Aziz Alawu, looking at really some of the questions related to patients who are in underserved populations to access precision medicine. We keep track of our productivity within the PM2C. So we make sure that if they are indeed using data related to the whole genome transcriptome sequencing, et cetera, that they will have an acknowledgement of the MOHCCN. So all of these papers you can see here have that acknowledgement. We have a CIHR-funded grant led by the hepatobiliary group. As you can see, Dr. Ganeka, Dr. Sapasochan, and Dr. Pugh with a CIHR grant that, again, leverages some of the the basic work that is being done by the HTC cohort in MOHCCN at PM2C. Just want a quick glimpse of what we are thinking for the last year for phase 1. For us, we're hoping to open a prospective cohort within our prospective sequencing group to look at rare cancers. We're going to call it Unicorn. It's not officially launched, but it will. And because we think that rare cancers are really important in the area of precision medicine. And I think we will work with Aziz Panorama Group to look at how we can support these patients with rare tumors too, with navigation and looking at different aspects of rare tumors. So that's something that is ongoing. And close to my end of my slide, I don't know why it shows this way. The Marathon of Hope in Ontario is also extended to various Ontario centers, and we are working closely with other Ontario centers, Kingston, London, etc., to really have them being part of the Ontario Cancer Consortium, of which we will be the secretariat, helping them to onboard and launch their initiatives. So with that, I'm actually the one giving the acknowledgement slide. I've asked the other two speakers to let me do so that they don't have to repeat all the thank you, so that we can do it now in the middle of the presentation. So this work takes a village, and you can see we have many villages. So we want to thank both the PM2C staff, the OICR staff, all the cohorts, all the coordinators, our patients, families, Terry Fox, and everybody else that I may have missed. This has been a very important collaboration amongst many of the groups. I think we should move on, or we take questions.
I think the questions will be at the end after
Okay.
all three presenters are presented.
Great.
So thank you, Dr. Siu, for that exciting update on the Ontario Consortium. And it gives me a great pleasure to introduce our next speaker, Dr. Enrique Sanz-Garcia. Dr. Sanz-Garcia is a medical oncologist and clinician investigator at the Princess Margaret Cancer Centre. Dr. Sanz-Garcia is also one of the consortium leads for Ontario, and today he'll be telling us about the prospective MOHCCN-O study and Molecular Tumor Board implemented by the consortium.
Thank you so much. Thank you so much, Jamie, for your introduction. And thank you, Marathon of Hope, for all the support, as well as for inviting us to present some of the work that we have been doing in the last few years. I'm going to present today, I'm going to focus on how we can bring whole genome transcriptome sequencing to patients and what is the work that we are currently doing at PMO2C. But before I move into that, I want to highlight what is Marathon of Hope Ontario. This is a protocol that allows patients to be consented for whole genome transcriptome sequencing, collect their tumors, and share the data across the Marathon of Hope network. And this study includes both retrospective and prospective samples and patients, and it has a few key aspects that I think are important to highlight. The first thing, we have a centralized approval through the OCRIP, which is the Ontario Research Ethics Board. We can include patients with solid or liquid tumors, and we are allowing also patients with prospective and retrospective samples. Those patients who are getting consented prospectively, they have also access to a clinical report that is issued by the OICR, and I will show you later what that entails and what are the advantages of that. And of course, because this is through the Marathon of Hope network, we will share all this data across the network using the CanDIC. If we go to the next slide, I want to highlight what we do in the prospective analysis from the Marathon of Hope Ontario cohort. So basically, we are including any tumor type, solid or hematological. And as I mentioned, there are two key aspects of this prospective testing. The first one is that a CLIA-certified clinical report is issued for each patient and sample. And second, this case is discussed in our Molecular Tumor Board, which I will show you later. Unfortunately, we cannot get whole genome transcriptome sequencing to every single patient in our center, but we try to be as flexible as possible, and we review each case in our tumor board to see whether it's suitable for analysis. We are looking for patients with high risk of recurrence after surgery, or patients with advanced disease or rare cancers, and also patients whose performance status and disease trajectory allows them to wait for 2 to 3 months to get the results. We are also involving our surgical surgeons, and especially want to acknowledge the hepatocarcinoma team led by Dr. Sapisochin and the head and neck cancer team, because they are contributing a lot for these patients in order to have fresh tissue from patients who undergo a surgery. In the next slide, you can see how the workflow from the prospective analysis works. I'm not going to go through all the slides, but I want to highlight that the key aspect, the thing that has improved the amount of referrals, have been the implementation of an online referral using our electronic health system, which is the EPIC. Now it takes less than 3 minutes for the MRP or delegate to enter that order in EPIC, and that goes directly to our team, which schedule the patient to be reviewed in the Molecular Tumor Board, and then if approved, it goes through all the consent of our team goes through all the consent of the patient, blood draws, biopsy requests, and obviously the tissue sampling to the OICR lab. As you know, we are going to share all this data through the Marathon of Hope network, but one key aspect of the prospective analysis is that we get a clinical report that is reviewed back in the Molecular Tumor Board. And then after that discussion that I will show you later how we do that, that report is uploaded in the patient chart, and the report is sent to the MRP, who can also get into those meetings and can explain to the patient what has been the conclusions and results of the report. In the next slide, you can see that it doesn't differ too much how we handle the samples from the retrospective or prospective analysis. We just take the tumor tissue, we do DNA RNA extraction, we collect the germline DNA using Buffy codes, and we also store digital pathology and also for immunoprofiling. In the next slide, you will see how our molecular tumor board works. So it's a weekly meeting. We try to alternate between days to make sure that they can come as much people as possible and to accommodate the busy schedules from clinicians and researchers. Initially, we thought that 3 members will be enough to making decisions, but the truth is that the median number of patients who are attending to this molecular tumor board of members is around 15 to 20. We review each patient for eligibility, and then we decide whether we move forward or not for the study. And then in the second part of our meeting, we try to review the reports that are available at that moment, and we discuss the clinical case from a clinical background perspective, but we also discuss the results with the OICR team, and then we put together a conclusion for every patient. In the next slide, you can see that we have a busy molecular tumor board. This is around 35 people at this moment, but we are trying to increase those numbers, and we are looking for more people across PM2C and hopefully in the near future across all the Ontario Cancer Consortium. You can see that we have a representation of different members of the institution, including clinicians, scientific associates, research staff, senior scientists, pathologists, and even we have a nurse specialist. But we also try to include clinical research fellows and postdoctoral research fellows, because we think it's important to train the new generation of clinicians and researchers into precision medicine and molecular biology. In the next slide, you can see how a clinical report looks like, and that clinical report is the one that it goes back to the MRP and to the patient. So basically, this is a report that is generated by OICR team led by Dr. Trevor Pugh, and you can see how we have a part in which there is a potential consideration of treatment options, and I will go through that, how we interpret that later in the molecular tumor board. Then you can see also how we represent the quality of the sample and the purity of the sample to make sure that the results are conclusive. And then there is a second page in which you can see the genomic and transcriptomic landscape. In the first part of the report, you can see that we include not only the single nucleotide variants and indels, but we also take into account signatures of tumor mutation burden, homologous recombination deficiency probability using different aspects, and microsatellite instability. And also, obviously, we take into account the RNA sequencing with the copy number alterations. All these characteristics and alterations are annotated with OncoKIB, with the clinical annotation of OncoKIB. And that's important because it guides us the discussion through the molecular tumor board. This report is presented by the OICR team, and as I mentioned, at this moment we are having these reports around 45 days from the moment that the sample arrives to OICR, but we are moving fast, and we are hoping by the end of the year to be able to deliver this report in 2 weeks. In the next slide, I want to show you how a molecular tumor board works in our center, at least using the Marathon of Hope or prospective analysis. So there is a clinical background presentation, usually done by a clinical research fellow, and then it's followed by the discussion of the results by the OICR team, taking into account the main aspects, but also the main limitations in terms of the quality of the sample. After that, usually the same clinical research fellow does a review of the data, taking into account what is the genomic landscape of the tumor, especially if it's not a frequent disease or it's a rare histology. And also we look into potential proof of experimental drugs, what are the implications of the WGTS in treatment response or in prognosis, and also whether there are some clinical trials available. We try to make this as participative as possible, and we open at the end of the time for questions and for potential considerations of the members, because we are a very diverse group, and we think that probably some people who are more familiar with the tumor type that we are presenting, they have more inputs to get into consideration. And the next slide, I want to show you one of the cases that we have presented lately on our tumor board. This is a patient with an hepatocarcinoma that had a high risk of recurrence after resection. And as you can see here, there has been 4 different treatment options proposed because the patient has, the tumor had an MDM2 amplification and a P10 deletion. Apart from that, we also review the rest of the report. We also look about the copy number alterations. You can see that this tumor has a significant amount of copy number alterations, and also that this tumor had an HRD signature. I want to highlight that in this discussion, apart from looking into the MDM2 alteration and see what was the success of those studies that are here proposed and what are the potential future options for this patient, we also look into the high number copy alterations in this tumor, and we found that there is some evidence that says that probably a high number of copy alteration in hepatocarcinoma is associated with less immune response, and that's important because if this patient recurs and there is no curative intent therapies, immunotherapy is on the table, and that may suggest a potential lower response than usual. As I mentioned, we look also in MD2 amplification and P10 deletions, and we put into perspective of the tumor type of the patient and the current situation of the trials that have been proposed. In the next slide, you can see another case. In this case, unfortunately, there was no any targetable alteration, or better said, any potential treatment opportunities based on the WGTS. However, we also learned something from these cases. The first thing is that this tumor had a mutation in this gene TNF-AAP3, which is not frequently observed in thymoma. It's only less than 2% of the cases, but take into account that this is usually not run in the standard NGS studies that have been so far done for thymoma. But the data that is right now, and this was put together by Diego, who will speak later after me, you can see that this alteration has a better prognosis. And that was something that we thought was interesting to share in our tumor board. But we also found this RAD50 deletion, and we were looking into whether there was any data, preclinical data, to suggest any potential actionability of this tumor. And we found that there may be a potential sensitivity to PARP inhibitors or platinum-based chemotherapy. But we also know that this patient was going to move forward with radiation after. So we wanted to see whether there was any potential predictive value of RAD50 in patients getting radiation. And it seems like it could be a potential predictive biomarker of poor response to radiation in vitro models. So that was something that we also brought back to the patient and to the MRP that referred this patient. In the next slide, you can see how we are doing at this moment. In the left side, you can see how we were doing before MTV, and now you can see how we are doing after MTV. You can see that in the last 4 months, we have been able to sequence almost as much as cases as in the last year and a half. And that's thanks to our team that has made a lot of effort to make sure that this goes along the clinicians, the support of the institution to try to get the EPIC referral in place that has made a huge success. And also because we are trying to allow also patients who have archival cases that we think that they have enough tissue to be sequenced, especially surgical. We have been doing better with this workflow in terms of registration to the time that the sample arrives to OACR. We are still trying to improve the numbers in terms of the clinical report, but I'm sure that we are going to be able to do that in the next year, and we will see that probably next year how these numbers have improved significantly. In the next slide, you can see here how are the tumor types that are right now in the molecular tumor board. You see that hepatocellular carcinoma, salivary gland tumors, head and neck, and breast cancer are taking the lead, but we have also an important representation of rare cancers. We are looking forward to include more rare cancers, as Lydia mentioned before in the UNICOR program. But I also want to highlight that there are other initiatives across PM2C that are doing prospective testing and whole genome transcriptome sequencing, and they have also some of them their own clinical report on molecular tumor boards, like for example, cholangiocarcinoma, hepatocellular carcinoma, pancreas, ovarian, and multiple myeloma. The last 2 slides are to see how we are going to move forward from now. The first thing is that we want to be more inclusive and include more hematological cases, and we are trying to get validated for clinical report the use of check swabs for germline testing. And this is something that is currently work in progress. We also are looking forward to report the germline alterations. We cannot do that at this moment because of bandwidth, but we are going to do that in collaboration with the Laboratory Medicine Program and UHN. We want to integrate all this data with the PMatch platform that has been developed by Trevor Pugh and Benjamin Heitkamp. And we want to expand the MD referrals, and we are going to include screeners in clinics to try to flag patients to the clinicians, as well as we are involving more surgeons to try to collect more fresh biopsies and fresh tissue. We want to analyze what is the impact of this analysis in patients and how the patients can interpret this analysis. And this is being led by Lindsay Carlson, one of our nurse specialists. And we are looking forward to open this cohort and this study in Ontario Cancer Consortium. As you may be aware, also, TFRI and Marathon of Hope are trying to bring this across all the country with a prospective study, and we are working along with other centers to try to get our experience and other centers, like, for example, BC Cancer, in place to make sure that what we learn from this, we can also transfer to all the country. So the last slide is my conclusions. I just want to say that this takes a lot of work and a lot of team. And I want to cue Lillian for all the acknowledgements before. But I also want to highlight that this is an initiative to try to bring whole genome transcriptome sequencing in real time to patients and to guide treatment decisions and help clinicians. But at the same time, this initiative is trying to improve the numbers in the goal cohort, trying to get more into our goal at the end of next year, as well as to trying to put together clinicians and scientists and learn from each other. Because I think for the success of this initiative, we need to make sure that both clinicians and basic researchers and translational researchers are on the same page. And this is an example of how we can do that. Again, thank you everyone for your time, and thank you for the invitation.
Thank you, Dr. Sanz-Garcia, for the excellent, exciting pullback of the curtain of some of the great research being done at the Princess Margaret Cancer Centre. Our final speaker today is Dr. Carlos Diego Holanda Lopes. Dr. Lopes is a clinical research fellow at the Princess Margaret Cancer Centre, supervised by Drs. Jeffrey Bruce and Philippe Bedard. Today, he'll be telling us about using shallow whole genome sequencing to estimate tumor purity. Go ahead, Dr. Lopes.
Okay, thank you, James. Can you hear me, everyone?
Yes.
Okay, thank you everyone for attending. It's a pleasure to be here and to share with you our results. Please, next slide. So I would like to start talking about a definition of tumor purity on the top part of the slide. The tumor purity is the concept that means the proportion of tumor cells in a tumor sample collected from biopsy or from tumor resection. It's an important metric once this purity can interfere with the NGS outputs. And you can see in the bottom part of the slide on your left side, if you have only a small proportion of tumor cells with a specific mutation, it could be below of the limit of detection of your test. So you cannot see this mutation, but as the opposite on the right side on the bottom part, when we have the appropriate number of the cells with the mutations, you can see this mutation in the report. So it's a very important metrics to be have in mind before to submit a sample to a next generation sequence approach. Next slide, please.
Veronica, somebody else share. There's some formatting issue with my Microsoft. You can see all the wording is a bit off. So I don't know if one of you can share it.
Yes, let me just give it a try.
Yeah, I think it's my Microsoft version is old, I think.
Can you see that?
Yeah, but
Okay.
You need to go to his deck. Sorry about that.
Yes, sorry, I should have started later.
Okay, so now the next slide. Thank you. So traditionally, the tumor purity has been determined as a standard by histology assessment by specialized pathologists. As you can see on the right plot, even in the same institution, the pathologists have some discordance between them. It's inherent of this approach, showing that you need to improve this metric for tumor purity determination. Next slide, please. And we have some molecular approaches that you can estimate the tumor purity. And one of them is the shallow whole genome sequence. On the left part, on the top of your slide, you can see the shallow whole genome sequence. This is a novel, time and cost-effective way to sequence the genome with a low coverage and a low depth of sequencing comparing to the whole genome sequence on the bottom part on the left. On the right part of your slide, we have this model that combines the output from the shallow whole genome sequence with the iCore-CNA that consists in an algorithm to estimate the copy number alterations for the shallow whole genome sequence. And with all this information, we can define the tumor purity of samples from liquid biopsy and from paraffin blocks. And as demonstrated below on the right part of your slide, highlighted in red, we have the same values of the tumor purity of samples using this approach, comparing to the whole genome sequence. Next slide, please. In the PM2C consortium, all the samples that has been submitted to the whole genome transcriptomic sequence, they must meet these two pre-analytical steps. First one is to have a tumor purity estimated by histology of 40%, followed by a shallow whole genome sequence to estimate a tumor purity of at least 25%. But to date, we don't have any data that could correlate these two approaches to see the metrics, to see how the characteristics of the samples can influence in the outputs. Next slide, please. Based on that, we developed this study with the main aim is to evaluate the utility of the shallow whole genome sequence combined with the iCore-CNA to estimate the tumor purity in samples submitted to the whole genome sequence that we go to call as deep whole genome sequence according to this workflow. The specific aim one is to define the accuracy of this approach of estimation of the tumor purity. The second aim is to compare the metrics of the histology assessment and the iCore-CNA with the shallow whole genome sequence, and also to investigate the influence of the sample characteristics with the outputs of the tumor purity according to the shallow iCore-CNA approach. Next slide, please. In the methods, we included the population of patients submitted to this workflow from June 2022 to August 2024. We retrieved sample features as the way of storage as fresh frozen or paraffin blocks, the site of specimen collection, the tumor lineage, the histological subtype, and the ploidy. Also, all the samples were submitted to three tumor purity estimation by histology, by the shallow whole genome sequence with iCore, and also with the deep whole genome sequence. And the third one was used as the ground of the truth, so we compared the results. Please, next slide. This is the table one that summarizes the sample that we included. So in a total of 507 samples with similar way of storage as paraffin blocks and fresh frozen. Most of them came from primary tumors. We found 3 lineages as carcinoma, sarcoma, and hematological, and also 20 different histological subtypes with a predominance of adenocarcinoma, squamous cells, melanoma, lymphoma, and neuroendocrine. Next slide, please. So these two plots show the correlation of the tumor purity estimation by histology, by the shallow, and by the deep whole genome sequencing. Please look at the left side of the slides. These box plots comparing the histology with the deep whole genome sequencing. On the y-axis, we have the output from the deep whole genome sequence, and the x-axis, we have the output from the histology. So you can see, looking to the x-axis, from 0 to 60% of the tumor purity, we have the same results from histology, but beyond that, we have an increase in the number of the tumor purity for histology and also for the deep whole genome sequence. On the right side, this plot shows a good person correlation of the shallow whole genome sequence outputs on the y-axis with the deep whole genome sequence and x-axis with a R quotient of 0.7, which is good for this type of assessment. It is very similar to the previous next generation approach to estimate the tumor purity. Next slide. Oh, I don't think this slide is adequate, but it's not, how can we see the slide in my screen? But I just want to show you that in some cases that the pathology disagree with the deep whole genome sequence. The shallow whole genome sequence can retrieve some samples, but I cannot see in this window. I don't know why. I think it's a problem of formattation. Next slide, please. In terms of metrics, I want to show you this table on your left that comparing some metrics of the shallow I-core CNA with the pathology on the two first columns. I want to show you that they had the same true positive results, but more false positive results with the pathology, more true negative results with the shallow I-core, and the same false negative results. On the right part of the slide, in these bar plots, we can see that the I-core CNA shallow had the same sensitivity than pathology, and then the combination of the approaches, but a superior sensitivity of the I-core comparing to the pathology, a superior precision. That means if the result is approved by the I-core, the rates of the result to be approved by the deep whole genome sequence, and also it had a superior accuracy of the I-core CNA with the pathology that shows which results of the I-core CNA that match with the ground of truth by the deep whole genome sequence, showing a good performance of the shallow whole genome sequence comparing to the pathology. Next slide, please. In terms of features that can influence the outputs from the shallow whole genome sequence, you can see this box plot on your left, that the histological subtype can influence the output from the shallow whole genome sequence. And the melanoma had the superior median of tumor purity estimation comparing to the other tumors. And when you go to the metrics on your right side, you can see the melanoma had a superior sensitivity comparing to the other tumors, and an inferior specificity comparing to the others. Next slide, please. In terms of way of storage, we found that if the sample came from a biopsy on your left side in these box plots, samples from biopsy that was stored as fresh frozen had a superior performance of shallow whole genome sequencing comparing to the paraffin blocks, but the same results were seen if the specimen came from the surgery. That means if you are using a small amount of tissue to shallow whole genome sequencing, so we should use the fresh storage. On the right side, you can see the performance, and also the fresh frozen had a superior sensitivity comparing to the others. Please, next slide. And to finish, we know that the ploidy, that means the amount of pairs of the chromosome in the cell, can influence the copy number determination. So we took a look if the whole genome doubling, that means the hyperploidy in the purple bars could influence in the performance of the shallow whole genome sequencing. And we found that the sensitivity was the same, but for samples with a higher ploidy, we had an inferior specificity to shallow whole genome sequences, showing that for samples with a higher ploidy, this approach can overestimate the results. So we should have this in mind if you select this approach. Next slide, please. So as conclusions, the shallow whole genome sequencing in combination with a core serves as a complementary method in filtering samples in a workflow for deep whole genome sequence. We found a positive correlation of the tumor purity estimate for histology, shallow I-core, and deep whole genome sequences, showing that they are looking for the same feature of the sample, but in a different ways. The shallow whole genome sequence overestimates had superior metrics comparing to the histology, and maybe we could optimize resources allocation by preventing the submission of low purity samples for deep whole genome sequence if we use the shallow whole genome sequence in this workflow. And also we found some tumor features that can influence the output from the shallow whole genome sequence, as the histological subtype, sample storage condition, and diploidy as well. So this is my first slide. Thank you for attending. Thank you for the team involved in this project.
So
Thank you very much. Sorry, go ahead, Lillian.
I'm saying we can take some questions. Sorry about the formatting.
Yeah, so people can put questions in the Q&A box, or you can raise your hand and we'll unmute you. I think we might have a question from James to start us off. James, did you have one, or? You're muted, James.
I do have one, but part of it was already answered by Dr. Lopes. You mentioned as part of your conclusion, you highlighted the importance of considering factors like cancer type and sample storage, as these can affect the accuracy of the shallow whole genome sequencing results. As part of your project results, did you and your team come up with any recommendations on how the samples should be stored in order to elicit more reliable and accurate tumor purity estimation?
Okay, James, thank you for this. The question is very important. Yes, when we are going to do the publication, probably we want to affirm the special and the appropriate conditions to use the shallow whole genome sequence, and we try to inform the best way to approach them, and which the specific features you should have and which specific features you should avoid to use the shallow whole genome sequence in this approach.
Thank you.
Thank you. Dr. Gallinger, you should be able to unmute yourself and ask your question. You're currently muted. Okay, I'm not sure if we can get that to work. Dr. Gupta, I see you have a question in the Q&A. I will try to let you unmute yourself as well if you want to ask it.
Hi, my question is from Enrique and team. So once you get the WGTS report back and you discuss in the tumor board, and I guess some of the, let's say, potential drugs are going to be off-label sort of, use and stuff and this thing. So are you collecting that data in your database of what did clinician did with the results, or you leave it to individual sites?
Thanks, Vikas, for your question. So I think that's a great point, and I think we are going to collect that. You know that this is discussed in the tumor board, and sometimes what we discuss there, it cannot be technically represented back in clinic because of drug access, right? But yes, our idea is to try to collect the data along with the MRP. At this moment, we have not reviewed too many cases to try to get you an estimation, but yes, that's the idea.
Thank you.
And also remember, every case is an MOHCCN-O case, so we have to have a complete annotation over time anyways. So we would be able to track that outcome anyways, right?
Yeah, that's it.
I don't think Steve can speak. Maybe he can type his question. He can try again.
Yeah, I think I've allowed you to unmute yourself, but you still have to unmute yourself, but maybe the Q&A will work better. I see Christine has a question. Christine, you should be able to unmute yourself. We can't hear you, Christine. I'm not sure if you're asking your question. Might be easiest to use the Q&A box for now. Sorry for these technical issues. Oh, Christine put her question in the chat. Can you use the plain language to tell me why should we patients be excited about your work/results? So maybe this will be a question for both of the speakers, Enrique and Diego.
Thank you. So I think patients should be quite happy about this because it's a way to try to bring precision medicine to patients back, right? I think one of the good points about this prospective cohort is that we are getting a clinical report in which we get some information if there is any potential treatment that that patient can receive. And that goes into the physician who takes care of that patient to have a face-to-face discussion with the patient. So definitely, I think that this initiative is going to impact directly on patients' care.
And also to add what Enrique says, we need to have a appropriate output from the next generation sequencing, appropriate report, so you can have appropriate plan for the patient. So with our results, we are trying to improve the quality of the outputs for the patients to guarantee if you are not missing any mutation or if you are overestimating a specific alteration. Our message.
Okay, thank you both. Dr. Gallinger put his question in the Q&A. Thank you for that. I'll just read it out. He says, I'm assuming that the shallow whole genome sequencing is being done to improve on pathologist purity calls. In that case, what about machine learning, such as for pathology as AI to calculate purity? I think that would be for Diego.
Okay, yeah, it's a good question. We have a project in mind to incorporate the artificial intelligence in pathology to estimate the purity. We have this in mind, and probably we have results in a few months, I think, because it's a very important, it's a better way to incorporate this to increase the metrics.
Maybe I can add to that. In fact, we actually had a backup slide, which I asked Diego to remove because he didn't think we have enough time, that we're actually actively thinking of working with an AI vendor to do so, because obviously that's where a lot of the efforts are ongoing with digital pathology. So great for you to ask that question so we can bring that back up.
Thank you for that. While we don't have new questions in the Q&A, I might ask one. This should be for Enrique or about MOHCCN-O. If I understand correctly, you were saying that the initial report is done through JIRBA at OICR, and then clinical fellows do a bit of a deeper dive in the literature and things like that. And I'm wondering how you see that scaling up, just in terms of resources and people power.
Yeah, so I think the good point is like we are a big molecular tumor board, right? As you see, we have 35 different people, and we are trying to make every people engage on this, right? So presenting these cases, it doesn't take too much time. It takes time to prepare because obviously you have to take 2 or 3 hours to prepare every case, and that's in terms of discussing those results, right? Hoping that in the near future this will escalate across Canada, because that's the idea that Marathon of Hope and TFI are looking for. I think probably doing a molecular tumor board across all the country is going to be very complicated, also because of privacy issues and so, right? But I think it will be a good learning for other centers, and we will be able to support how this is being done. To be honest, we are not the first ones to do a molecular tumor board with whole genome transcriptome sequencing. Some people here at UHN, they have been doing that for the last year or two, like the pancreas or the biliary tract group. And also in BC, they have been doing this with their own with their own report, right? But I think we can also help others to learn about this. I don't know if this have us answered your question of how we can expand this.
Yeah, thank you. Andre?
Yes, thank you very much. That was very nice, Enrique. So my question is kind of a bit similar to what you just asked, but more, so when you think you're going to be full speed with this, with referrals from other places in Ontario, how many cases a year do you think you will be doing?
So that's difficult to know at this moment. We want to make sure that this study is open in other sites from the Ontario Cancer Consortium, right? We think it's better for the patients because they don't have to drive to Toronto to sign consents and so. But at this moment, the metrics that we are having right now, we are getting 3 cases per week, right? One thing which is important is that the more cases that we are able to perform, the fastest the clinical report is going to come back, right? Because OHCR then can put all the samples in a batch together, and that will simplify all the process, right? I know Trevor and all his team are trying to catch for that workload that is going to come. And that's the reason why we are also going to partner probably with the laboratory medicine program here to try to get the germline testing, because OHCR doesn't have bandwidth to do everything, right? But yes, we are working on that because we know that it's going to be complicated for us to handle all the cases. But the idea is that we will try to make sure that every center on Ontario Cancer Consortium, if they want to be involved in this study, they can do themselves in their center.
Right. So yeah, so now you're doing about 150 cases a year, right? So you say 3 cases a week. I mean, will this double, you think, in the next few years?
We will see how it goes. I mean, we have just started right now, the last 3 months to do this process. Right. And the metrics right now are 3 cases per week, right? Sometimes we have 5, sometimes we have 2, depending.
Yeah, got it.
I think it's also a matter of all the clinicians to get involved on this, and this is what was more difficult because of all the logistics. Now we are getting that here, so I think we will be able to target that 150 or even 200 cases per year, hopefully more. But I think that's realistic.
Right. Okay, good. Thank you.
Thank you, everyone. I'll just mention a couple comments from the chat from members of our patient working group saying how exciting it is to see precision medicine in practice really moving forward. So with that, I think that ends our questions. I don't see any others in the chat or the Q&A. So I want to thank all the speakers for their wonderful presentations today, and James for being a fantastic co-chair, and all of the attendees for joining us today. Thank you all, and we'll see you again in a couple months.